Thank you very much, Adam, for this nice introduction. Thank you very much for Federico for organizing this, for including me into this. I appreciate this very much. So it's very hard after these two really outstanding talks to keep that level. But I hope you see my jacket. That's a real Givenchy jacket. On each bottom it says Givenchy. And there's a story, this is immensely expensive, I'm telling you. It's no kidding. It's immensely expensive. And I didn't buy it. So someone in Paris, there was connections, gave me almost for free. Some years ago, and I thought, wow, Givenchy, this is going to change my life. And it actually did, just in a negative way. It's hanging in my wardrobe, and every day I'm opening the wardrobe and see the jacket hanging. And over these years, I never wore it. It's the first time. Can you imagine, you're living in the German-speaking world and dealing with side effects, meeting people interested in side effects, you never get a chance to wear Givenchy. So, and then I had this invitation, ALPS, French-speaking, a little crazy people. I thought, wow, the time of my jacket has come. So don't spill over coffee or anything. It's really precious, I tell you. Okay, but now adverse effects. So I'm now the bad guy. I thought all positive talks, but now I'm telling you really serious bad stuff. You see, you may think that dealing with side effects is boring, but in fact, it's not. It's like criminology, all the companies hiding the side effects. So it's really interesting. And here it's particularly interesting. You see here, there was a debate, inside or insanity. So there were anti-LSD media campaign by the US government that claimed severe psychological and physiological damage from psychedelics in the 1960s. People might go insane, they said. Schizophrenia-type symptoms were reported, accidents, suicides, and even chromosomal damage. It's interesting that the early pioneers all wrote quite a bit about side effects, so they're early on. For example, Timothy Leary had a wonderful book, The Psychedelic Experience, and there he writes, "You are entering now nightmares, followed by momentary sorrow of great intensity. You will go through sharp mood swings. Do not fear them. They're all determined by karma. They are divine tests." So each side effect you may occur is just a divine test. So finally, there are no side effects, or they're all spiritual in nature. A bit more differentiated is Prof, I think a very, very important pioneer of, for example, LSD psychotherapy. And he says sedatives can do much harm in the course of psychedelic sessions. He thinks about sedatives given for reducing side effects. Even the most dramatic negative LSD experiences have a strong tendency toward positive resolution, and if resolved well, they are exceedingly healing for the client in the long run. Very interesting statement, and I will tell you more about this, but certainly this is the experience, also my personal experience, but really it resolves in many patients. But if you see more modern authors, for example, there's an interesting book, Psychedelics and Psychotherapies, by these kind of guides, many underground guides, with a lot of experience. And this Andrew Feldmar says it's a very complex task to actually be there with someone who is in an altered state of consciousness. The possibility of alienation, the possibility of making things worse is enormous. So the gains are high, but the dangers are also great. And this book is full of this kind of comments, so it seems in this underground, there's kind of a transformation that people are more and more aware of side effects. And also when you think Ram Dass, when he was very old, he also said, be aware, psychedelics are very dangerous substances. So you see, there is a Swiss Society for Pharmacovigilance in Psychiatry. They counting all the side effects, and I'm the proud president of this society. So over decades, we assessing, collecting data on side effects of psychotropic substances, interactions, and we work with teams in Germany, in Austria, and with Medic. So over years, I have a lot of experience how to assess, how to interpret side effects. And certainly clear, you cannot come in Switzerland, for example, and say the side effects is a divine test. There are really strict regulations. For example, they say here an adverse event in a pharmaceutical trial, any untoward medical occurrence in a patient or clinical investigation which does not necessarily have a causal relationship with this treatment, or adverse drug reaction, all untoward and unintended responses to a drug related to any dose or procedure administered. You'll see all the procedures, so the setting is excluded. So if the setting is adverse, it would count as an adverse drug reaction. It's also really difficult to say this then in psychedelic therapy. It is unintended, so what you attend, if you go to an ayahuasca ceremony and you intend to have a very unpleasant experience, then it's intended. Or in German, it's also interesting, also in French, we say unerwünschte Arzneimittelwirkung. In French, I think effet secondaire indésirable or effet indésirable. So it means what you don't want. So it depends what you really want and depends what the therapist wants or what the patient wants. And you see there is no standard assessment, so it's very difficult to compare studies or to do comparison between psychedelics trials and like the antidepressant trials. And certainly what you see in these underground or in these not so no high quality studies or old studies, there's spontaneous reports of participants and observations by therapists. But it's really not a good method, as I will show you soon. The real method are structured interviews or structured questionnaires, for example, a challenging experience questionnaire, or the Fribourg psychedelic side effect scale that we are currently developing. And what you saw in Frederica's talk, blood pressure, body temperature may be important because there's still quite an important cardiovascular effects of these substances. Just to show you an example here, this is a study on meditation, mindfulness-based cognitive therapy. It's mostly meditation over 8 weeks. It's a woman called Britton, did really the right thing. And she asked, now you see how you assess this, how many had any side effects, so unpleasant effects, 83%. And how many thought this is negative? You know, it could be unpleasant, but still a good thing. But still 58 thought negative valence. And then 33% reported that these side effects had a negative impact on their lives. And even up to 15% are lasting bad effects. So that's just meditation, but you see there is an important underreporting and under-publishing of side effects of meditation, also of psychoanalysis, of psychotherapy. They have very high unpleasant effects. And here it's very hard to interpret that if they say lasting bad effects and they say, no, it was a divine test. Because, I mean, they telling you it was lasting and bad. Here, certainly, we have a specific characteristics of side effects of psychedelics. This is data provided from Guy Goodwin from Compass Pathways. It's very interesting that you see you have a lot of side effects on the dosing day, where you have a good setting, and then a very low rate of side effects. So of all adverse events, 68% reported as starting and resolving on the day of administration, and the median duration of these AEs in all treatment arms across 12-week trial was 1 day. And that's a bit the problem just for regulatory purposes, because usually we count side effects. It's a very primitive method. So you do an 8-week trial, so it's not necessary, and you count the numbers of side effects. You don't measure the duration. And that leads, so yeah, I show you that psychedelics have quite a lot of side effects because of this system. So I think there we have to make sure that the system changes, and we do assessments where we measure the duration of the side effects. They may be really short, not in all cases, but in most cases. But let's go back to this discussion in the 60s. Is it really dangerous? So is it toxic? Very low physiological toxicity. We can say no evidence for LSD, mescaline, psilocybin having neurotoxic effects. Few animal studies showed neurotoxic effects of MDMA in high doses. We heard about this from Federica. Can be addiction. High doses can be neurotoxic, but not in the therapeutic setting. And LSD does not bear a significant risk of chromosomal damage. So that just was made up by these politicians. So there's no evidence for physical dependence, excluding MDMA. There is dependence. Some physiological side effects like dizziness, nausea, and headaches are quite common. Then the psychological side effects. There is a risk of a bad trip, indeed, in patients more than in healthy controls with anxiety, dysphoria, panic, paranoia, especially in unprepared individuals and in uncontrolled situations. So here, set and setting are really important. Then the risk of prolonged psychosis, mostly in individuals with premorbid mental illness. That's why we exclude patients with psychosis in the past and family history of psychosis. And there's still the open question, can psychedelics cause psychosis or just shorten onset time? I mean, if you have this risk, so I will show you there's a twin of a schizophrenic patient who becomes psychotic. Is this really causal, or would this person have become psychotic anyway? There is, in few cases, this hallucinogen persisting perception disorder, HPPD, a term you have to know if you're interested in the pharmacovigilance of psychedelics, very rare, and suicide have occurred. They are rare and in unsupervised settings, but certainly there is also suicides in other kind of pharmacological or psychopharmacological trials. So here you see now, someone asked about the data from the 60s. You see, I show you Sidney Cohen was a very prominent psychiatrist, the early critical voice, fought against Leary and his overly liberal attitude. But he was very critical, said it's only 1 per 1,200 non-patient participants had a psychotic reaction lasting more than 48 hours. And this was his identical twin of a patient with schizophrenia. And prolonged psychotic reactions over 48 hours were slightly more frequent in patients undergoing psychotherapy. That's one important distinction he made because healthy control, we saw a lot of data today on healthy controls, but there may be more side effects in patients. But you also saw these problems. I mean, psychotic was not defined as we would define psychotic. They were certainly not psychotic in a modern sense. Psychotic means really a strong disorganization of behavior and speech. But at that time, almost every kind of strange symptoms were psychotic. And you see many problems. If you look, only 44 or 62 research turned surveys results these kind of problems they had in these studies. So I know coming to data from Franz Vollenweider sitting here with his colleague Eric Studerus. They did important work. It's way better you look at side effects when you use trial data, because then it's a very controlled situation and you have a comparison group. Because many symptoms, or even psychosis or suicide, can also occur in the placebo group. And they looked at 8 double-blind placebo-controlled experimental studies with psilocybin in healthy participants. And you see the dose, they had kilogram per body weight, but it's about 5 to 25 milligram. I think it's rather low dose. I will show you the higher the dose, the more side effects. And they found that indeed some people reported after some flashbacks, altered state of consciousness, but this was not more frequent than before. So there are people in the population with this kind of flashbacks, but they didn't increase through psilocybin. So no significant difference in intensity, duration, etc. from before to after. These were always linked to certain triggers like music or meditation and therefore controllable. And 3 subjects reported minor visual hallucinations, not comparable to symptoms of this HPPD. But still, I mean, they had some minor visual alterations. And then they looked at changes in well-being over days and weeks. 7 subjects reported subtle negative changes in well-being related to psilocybin experience in the first weeks of treatment, still 8%, I think. Concentration problems, mood swings, reactivation of old problems, memory problems, being pensive and introverted. And one subject mentioned rather strong irritability, anxiety, and depressive feelings, and thought professional help for afterwards. After 2 sessions of psychotherapy, symptoms stabilized. So it's pretty safe, but it's not absolutely safe. And I think we have to inform patients and healthy participants in study about these findings. So Franz concluded, only a few participants with high doses experienced strong acute adverse effects, and these could be handled by experimenters. In 110 subjects, no one experienced psychosis, HPBD, or other long-term impairments in daily life. We're also healthy participants. Positive changes in attitude and values after the experiments were common. And 7 subjects reported subtle negative changes in well-being in the first few days, weeks after the experiment. And altogether safe and healthy and well-prepared subjects in a professional setting. You must all see they're all the highly selected people that you include in such studies. We stay with Vollenweider. He did really very important work in this field as side effects. Here you see many dimensions of the MDMA effect. It's a small study. They were better in extroversion, they were more excitable, they had better emotions, but you see here this anxiety also went up. So anxiety is here, let's say, an unpleasant effect, but they write made up mainly by thoughtfulness, contemplativeness, dreamy, thoughtful, etc. So, I mean, a little bit of anxiety mustn't be a bad thing, can be a good thing. Certainly, if you look into other world, if you open our heart, it's, I think, quite normal. That also makes a bit anxious. But if you go to the somatic side effects, is still, you see this jaw clenching, lack of appetite, difficulty concentrating, impaired balance, gain, restless legs, perspiration, heavy legs, etc. Still 2/3 had somatic adverse events, and 1/3 some adverse events after 24 hours still present. And one case was still transient severe hypertension in one subject. So you certainly have the option to measure blood pressure in your therapeutic setting. So now we come to a study, also the author is here in the room. They did a very good study just published on safety pharmacology of acute LSD administration in healthy subjects. You see here, that's not the author, but it's Paulina. She made these slides, so the paper doesn't have any figures. She made some figures. You see this good-bad effect we learned today. That's also what I'm using in my studies. I mean, because Matthias Licht told me to do that, I think it's a good measure. So you can every hour, for example, ask this. You see an LSD still 1 or 286 has any good effects, and you see half oceanic boundlessness, and bad effects still in 24. It's a bit more on the higher dose. And some of these are anxious ego dissolution or other kind of anxieties and other kind of bad effects. Then when you see blood pressure, we heard that today there is some increase in blood pressure. So it's certainly not a big concern, but something to know. And we heard these whole findings about heart rate and the different substances. And you see the heart rate. We heard today, it's really amazing, 73 to 90, that's something. I mean, it's really a physiological effect that people can feel and say, my heart is pounding, and they are not psychotic because it's just realistic, and also temperatures goes a little bit up. It's certainly not something as Leary thought. He thought all side effects are psychological in nature. I think that was not correct. Then what's very interesting in these studies, they looked at a subacute effect. So after the acute phase, the other day, what they felt. And you see that still a subject feel of weakness, 24%, lower in the lower dose. You see there are many advantages in the lower dose, or feeling dull, still not very pleasant, at full day feeling dull, or lack of energy, up to 24%, or tiredness, 55%. So the day after, certainly, there are some side effects quite common after LSD in healthy participants. Then what's interesting here is these curves. I'm doing these curves for all my patients. So you see that this good effect, I mean, there's some definition. I mean, we had to do a cutoff. That's why sometimes here with some cutoff. And then you see the good effects, they are the same peak, but they're bigger, and then they go down. And what you see here in the beginning, you have I call that a mixed state, good and bad effects. But interesting, at the end of the session, you have a phase with mostly positive effects. That's also my clinical experience. If you go to 200 micrograms, that's basically the same thing. Did it do it? Yeah. Just there are some more negative effects, and they're a bit longer. So this phase where you have only positive effects is a bit smaller. Here you see that's Clarencia. That's what Adam said. All the people working in my lab, it's really fantastic. They're coming. A lot of interest and also competency. So she just made a figure of all the patients I treated. I mean, I treated way more, but that's just only with LSD, where we had really good data, 19 sessions of 14 patients. And you see a bit the same. This is the intensity of the whole substance. You see the negative also starts here and is lower and goes down. And what you see here now in my study, the green keeps up. So many people, even at the end of the session, have the total intensity goes up, but still they have very positive effects. And I think patients like that. It's a good phase also to discuss certain things, or a good moment for the patient. So here it's descriptive, but it goes really in the same direction. It just adds some complexity to it that Peter Gassi describes a patient with 2 sessions. And I must say the side effects rate may change over time. So it's rather decreasing over time, but just that you get a bit an impression what they feel. So this patient said the first trip was a panic trip with almost pure fear of death. It's still amazing, fear of death. It was agony. Really, I had the feeling that I'm dying. Yes, it was just really black, the black side. I was afraid, shaking. It was total exhaustion, not seeking an exit, no escape. It seemed to me like an endless marathon. That was a big part of the trip until it finally led to relaxation. During the second trip, the dark side also showed up at the beginning, but for a rather short time. It was a little tense, sweating, but not for so long, and suddenly a phase of relaxation came. Completely detached. It became bright. Everything was light. It became a pleasant feeling, a warm feeling, no pain, almost a little floating, clear, being carried, and together with the music, it was really gorgeous. The key experience is when you get from dark to light, from tension to total relaxation. There are many very interesting details here. For example, endless marathon. Be aware they have a totally different time perception. Time is basically standing still. So for them, these 2 hours, unpleasant experience, sometimes it takes them, it feels like it was days and days in the bad experience. So that's a rather negative thing. But what you see in the second trip, it was better. And exactly what I showed you before, this is exactly the point where you see these shifts from the negative maybe dominating over the positives, but the negative go down, and then you get into this light. It's, by the way, I think Grove also said that it's birthing process. It comes like a birthing process, because here you have the labors, and here kind of is a birth. Or you can imagine, interpret this in terms of birthing. So that's why I understood why Grove always used this metaphor. Okay, let's do another study, Carbonara from the Griffins group, and they did something not really correct in my view. They sometimes do very strange things. I say they go out and say we do a survey retrospectively, but just interesting people who had challenging experiences. So and they want to report about the challenging experience. And then indeed, they get these people, they say it was very challenging, top 5 or top 10, this is the most challenging experience in their lives, but also the most significant, and the well-being increased, and they do some statistics, and they see the more challenging, the more increase in well-being. And that's a common notion, an interesting notion, a notion that may be true. By the way, an idea that was also in psychoanalysis. So in psychoanalysis, also it must be very difficult sessions. And out of these extremely difficult sessions, where maybe the analyst is sleeping or crying or I don't know what, shouting at each other, that's good for the course. But when I was young, I did a lot of psychotherapy research. This was never the case. If you really go in psychoanalysis session from session, it's amazing. The more positive sessions, the more the positive outcome. It was never shown this, that you really need extreme challenging situations in psychoanalysis to get a good outcome. Also, it makes sense to me, but it never showed in the data. But in retrospect, it may be really the case, and maybe it's really the case, but I will show you more data. Just that's not the way how we would do it. We would really measure the challenges like I do it, and then to measure the MADRS over time, and then see if it's really true that the more, say, unpleasant feeling leads really to a better outcome. I will show you data about this soon. But here it's still, with Griffin's, always some interesting things. I mean, he's really extraordinarily intelligent person, I think. You learn a lot. They ask them what helped them in a difficult situation, what to do. And here you can learn a lot. So try to calm your mind, for example. So you do some mindfulness exercises, change location, use your body to shift the experience. Many shamans know that. It's difficult. You sit up or you lie down. You change your body position or change the music, can be very important. Change social environment, ask for help, smoke cannabis, drink alcohol. Sometimes we give some benzodiazepines. But that's really the thing what we have to do. I mean, side effects, I always say it's not something not to do. Side effects is always something to manage. And here it's very easy because all the side effects are in these 12 hours or 8 hours you are with the patient. So there are many things you can do against side effects. And I think it must be the competency of the therapist. And I think the competency cannot be just say all what they experience are divine tests, but sometimes you really have to do something. And for example, shamans know a lot what to do with these kind of situations. For example, here is such an example how a side effect resolved from a psilocybin study, end-of-life anxiety. So this person says, it really hit me very strong. And it was terrifying. It was just terrifying. I was completely disoriented. I was really maybe in the hold of a ship at sea, rocking, absolutely nothing. Nothing to anchor myself to. Nothing, no point of reference, nothing. Just lost in space, just crazy, and I was so scared. And then I remembered that Tony and Michel, these were the sitters, were right here, and suddenly I realized why it is so important that I get to know them and they get to know me. And I reached out my hand and just said, I'm so scared. And I think it was Tony who took my hand and said, it's all right, just go with it, go with it. And I did. You see here how important the guides are. We heard yesterday something very interesting in ayahuasca. People sometimes speak to the mother ayahuasca. It's like a person, and then there's less guiding because you can talk to the substance. But with LSD, psilocybin, it's rare. So the guide is really important. So you see this person is totally lost. Sometimes they're totally lonely. And then the guide is really important. And also see, I mean, that's just in Switzerland, he said, oh, it's important that they know these two persons. So that means the day before he got them to know. I mean, Switzerland, that would be crazy. So we know them for a while. But it's an interesting remark that that's what Peter Gass said about industry. They think, yeah, there's like a machinery. They come in and they don't even know the therapists. So you see, that's not a good thing. I mean, this person clearly tells it's important that you know the guides. I mean, it sounds trivial, but you will see that industry may see that differently. Okay, now we switch and go to patients. As I told you, there may be way less side effects in healthy controls than in patients. So in my really severely depressed patients, I see really a lot of unpleasant effects. And here these various famous studies from Card Harris, one of the really cornerstones of the psychedelic renaissance. And you see there were just 12 patients, but you see adverse effects. All of them had anxiety, so all of them had a side effect. That's clearly way more than in other studies on SSRIs. That's a lot, 100%. And still 9 had this confusion. I mean, that was not positive really. That you see a lot in patients. They sometimes are confused, even in the integration phase. That's, I think, it's a real problem. It's not always resolving, so, but sometimes it does. Nausea, headache, and paranoia may also appear. That's also quite unpleasant, difficult to deal with. But at least all adverse effects were transient and mostly mild, no severe or unexpected adverse events. Here, so the study was mentioned before, one of the really very important studies to show the potential, but also to remain modest. I mean, Peter showed you the results. I don't have to repeat them. So it's like the same efficacy, a little more than escitalopram. And there are certainly tables about the side effects. You see any adverse effect, psilocybin 87% and SCOs 83%. It's about the same. And related, it's adverse, we call it in Switzerland adverse drug reaction, you 73 and 79. So you have the same amount of side effects. Certainly, I told you that's this counting system. They just count the side effects. Also, when you look at headache and many things, it's very, very similar. Just fatigue is less than fatigue, for example. But maybe that's an over-reporting of side effects of psychedelics. If you do the duration, which I think is very important, you may see that in SSRIs, these are sometimes long-term side effects, and here it was just acute side effects. It's also interesting, one important side effect of SSRIs, not of all antidepressants, is emotional blunting. And they write here, when cued to report on specific emotional and side effect-related phenomena through some scale, patients in the psilocybin group report a greater perceived improvements in the ability to cry and feel compassion, intense emotion and pleasure, and report feelings less drowsy than those in the escitalopram group. I think it's really an absolutely crucial finding. So, you know, all the drugs we're using are mainly inhibitors. In one way or the other, they inhibit. I mean, there are exceptions, but antipsychotics inhibit, SSRIs make a lot of inhibitions. And that can be really, really subtle inhibitions, but it's still always an inhibition. And that's here completely new. You have a substance that makes you more sensitive. It's a dangerous substance because sensitivity is just good if you're in a very good environment. If you're in a very adverse environment, sensitivity may be a bad thing. But it's really exceptional that you have a substance that's also shown in fMRI study where you increase the responsivity of the amygdala. I think that's one of the real points of revolution. Another aspect, and I think that's extremely important when you are in the side effect business as I am, you always look at these kind of graphs. You see there 1,000 people wanted to be included in the study. And what they did, finally, they took 59. And that's way more. I mean, it's always maybe you get half or so, or in a psychotherapy study, also maybe 1,500 here. But that's extreme, from 1,000 to 59. So you can say in these studies, they are carefully selected. And this may change the whole picture if you start to take everyone, like in industry-sponsored study, and you don't do this. Or you say, okay, it's just, we don't know exactly what they did here. If you look at these exclusion criteria, it doesn't really explain you why this amount of people were excluded. But this is going to be a real problem. Maybe it's just for a small group of patients. So that's one of my biggest concerns. It's not for the general population. So that you have to have a high IQ or certain personality features not to be confused and to really profit. But we had the same in psychoanalysis. I mean, psychoanalysis is also just for some intellectuals. I think it's also not for everyone. It's not new, but it's different from SSRI, must see. SSRI is really for everyone. I mean, that's a very different picture. Okay, but let's go to another, I think, tremendously important study. That's the study in Nature Medicine published on MDMA in PTSD. I mean, that's where we're really close to getting really this license and into market, that they showed, as you see, PTSD is measured with these caps, and you see a clear reduction in caps, very well done study, 3 dosing sessions, psychotherapy integration, great study. I think Rick Dublin was kind of behind the scene. And here you see also what's very important, depression score. I mean, most of these patients are also depressed, and really a clear reduction in depression. Very amazing study. And here what you see, the side effects. And you see here, 63%, you may remember what Vollweider reported, 63%, it's the same amount. So it's not more in these patients with severe PTSD. So you have still this kind of somatic side effects. If you go down to stress, 8.7%, to nervousness, 6.5%. I mean, that's really hallelujah, I have to tell you. That's really the most, I think, amazing fact I read as a side effect expert. That's way less than meditation. That's way less than any kind of psychotherapy, way less psychoanalysis. That's almost crazy if this is true. But Peter Hoen told me in the very first meeting with him, you know, MDMA has like a protective factor. You will see it's like protects even patients you couldn't treat with PTSD, give them MDMA, they are protected by the substance. And that's exactly what you see here. And I think this may really be one of the revolutions that we can treat trauma patients we could not treat with meditation, mindfulness, psychotherapy, that we can treat them. So I'm here very, very optimistic. Okay, then I want to show you, even in the interest of the psychedelic renaissance, you have to really assess properly side effects. I show you. Before you treat, you have to know, in a way, are they pre-existing? I mean, that showed you also in this study from Franz Vollweider. Many people have some psychotic symptoms or some headaches or I don't know what. So you know that's all pre-existing. And then if this is present after in the treatment, then very important, the duration of the side effects. And you have a list. It's a very long list. It's just the beginning. The valence, do you think that was positive? I mean, if they face trauma, they may tell you that was unpleasant, but it was plus, very good valence. It was very important for me. The impact, I mean, that's very interesting. They say, no, it was horrible. I couldn't talk to my sister anymore or so. Or they have very positive impact. They cried because they saw scenes with their mother, but at the other day they called the mother. I had a patient for 20 years, didn't talk to the mother after the MDA session, talked with her mother. So it was horrible, the trip, but it was an extremely positive impact. Relatedness, that's very pharmacological. How much is it related really to the substance? And did it need any intervention? As we read, for example, psychotherapy or drug therapy or headache, painkillers or anything kind of this. And so there you have really good data to show that may be the case, that we have a lot of side effects, but the valence is always positive. That's the hypothesis of Leary and Grof in a way. Okay, but I also think we have to come up with an embedding of psychedelic treatment in psychotherapy. And I really think psychoanalysis is not the way to go, because it's just not a very scientific measure. There's very unclear terms. It's really, there is like modern psychotherapy research, and we have we know how this may work. And one of the really good treatments is acceptance and commitments. It's based on behavioral concepts in psychology. This is kind of very close to psychedelic treatments. For example, here is a new manual. There are tons of manuals, and mostly are really so hard to read, but then this manual is really very good. It's very easy to read. For example, they write, the purpose of acceptance exercise is not to reduce emotional arousal, but to learn to stand in the presence of private experiences while functioning in a more free, flexible, and values-based way. Or it says, it is important to look for in-session opportunities to actually practice acceptance rather than merely talking about it. And that's a real problem in psychotherapy. Many of the patients that come, they say psychotherapy is not working. They talk something, or they're very abstract, or they have no focus, and they never get to the real point or the real problem. And I think psychedelics really help to get to this point so that this process of acceptance can occur, and you can really help the patient processing these emotions. Another aspect, that's now a slide I'm using for managers, exactly people with Givenchy dresses. And you see, I didn't change it. It's just word they said to achieve self-efficacy, to achieve a positive change in the environment through one's own activity and competence. So you do something, I don't know, you think you're so lonely, and then you speak to someone, and then it goes well, and then, yeah, I want to do it, how to do it, I can do it. And this success finally leads to raising expectations, and you do more. And you just have to change a little bit, change in the environment, just a change in the inner environment, and then we are already very close to psychedelic treatment. I think really self-efficacy, why these people of challenging experience are so happy about this is because they have these self-efficacy experiences. And finally, many patients they have difficult emotions, and they're completely by themselves. They're lonely with their emotions. And here may be really what we call this corrective emotional experience. That's a bit from psychoanalysis, by the way, that they have these difficult experiences. So important that they don't have this transference on the doctor. It should be rather positive transference. When you see the patients, they're very difficult interactions. It's better not to do it, so you need like a simple doctor-patient relationship, and then it's possible, I mean, if you need the handshaking, that's another topic, I don't want to go into this, but there's someone there who helps you, understands you, and understands the situation, is an expert, and this may also think one of the factors why this challenging experience may help. But certainly to say, like Griffins a bit, and Grove and Leary, that you need the challenging experience is certainly not correct. Here they made it the right way. They measured positive and negative experience and related it to the decrease in depression symptoms. And you see clearly the more positive experience you have, the more you have a reduction in depressive symptoms, and you have negative. The more negative experience you have, the less it works for depression. So that's also what is in psychotherapy. It's just a myth a bit that you need challenging experience, or what kind of challenge may be the case, but still very good data from Cart Harris and this group. So you cannot, it's still a good thing as a therapist to see that the patient has a pleasant experience, I think. Another thing I really like is that patients have options. Here you see Adrian Hase, one of my great collaborator, and we are doing so new kind of linguistic research. We have thousands of drug reports collected, and then we do linguistic analysis. For example, how many positive affective words were used in these reports. And you see a very clear picture. So if you want to have positive emotions, go for MDMA. Now, if you really want to have a negative experience, it's interesting, don't take a psychedelic, take an antidepressant. Now, that is certainly a joke, because here you have a selection bias. Certainly they're depressed patients, they're not depressed patients. It's just a joke, but it's too good a joke to miss. But if you see low emotional words, it's MDMA again and DMT. So what we heard from Peter Gasser, Peter Oehen, all these SAP people, that's what they say from their experience. MDMA may be really a good beginner substance, a substance for patients with severe disorders. that's really here as shown in this data. MDMA may be really a good starter, and you see the other drugs. Also, it's very interesting when you see ayahuasca, it's more negative than just DMT. So there may be many healing substances, but it's way more complex, many alkaloids, and this may also lead to more negative experiences. So in summary, in my view, there is no need to divinize, idealize, or romanticize side effects of psychedelic substances. So they're just too short and too mild. High dosages produce more adverse effects than low dosages. It's a very consistent finding. So start with low doses, and just if the patient really likes the unpleasant experience, go to high doses. MDMA may be the psychedelic substance with the lowest level of adverse experiences. And some non-specific adverse effects of psychedelics may not have psychodynamic or spiritual meaning. And just say, the Biss Grove also points out they're all psychodynamic. So everything the patient's experience is for him out of the unconscious. I don't think that's true, because they're so, this jaw clenching, even interprets jaw clenching as things in a previous life they were at the dentist or so. I don't think that. Or then we're all at the dentist, all these 65% of MDMA users. Okay, nevertheless, adverse experiences in psychedelic therapies may be part of the therapeutic process, bearing resemblance to psychodynamic therapy, exposure therapy, acceptance, self-efficacy, and corrective emotional experiences. Here I want to say thank you. People helped me with these slides. I mean, I really don't like to do all by myself, so I always ask people to help me, and they help me a lot to come up with these slides. Thank you very much. You see here my lab. No, that took a lot of. Okay, and then I'm open to, I don't know if time to questions or discussion. Thank you very much for your attention.
All right, so let's take 12, 13 minutes for questions.
Hi, thank you for your presentation. I have a question, and in a way it's related as well to the previous presentation. We're talking about this Renaissance. And of course, not by coincidence, the European Renaissance happens at the time that we are getting in contact with other cultures that give us sort of the foreign perspective of looking into ourselves and understanding the absurdity and rigidity of our conventions. And in this sense, I would like to know, because I see there's a lot of parameters, you were even studying the presence of positive words linguistics. I've never seen information about the background of the subjects in terms of their profession, their class, and I wonder if some of these negative adverse experiences have to do with these people understanding these patterns of exploitation, of injustice that are present in their lives, but they are completely impotent to change.
Yeah, I think that's a very important question. So in my clinic experience, it's clearly the case. So people had negative experiences, then they have more unpleasant experiences. Unfortunately, these linguistic reports, we don't have a lot of information on the reporters. That's a real problem. That would be great to have really a lot of educational level, etc., of these reporters. Unfortunately, we don't have that. But I think when we do larger studies, that certainly has to be done exactly. I mean, there's some studies by Cart Harris that people with a lot of self-consciousness, I mean, they're already very open, they profit more than people who are totally non-self-conscious. That's also a problem. I mean, so if you take someone who's absolutely not self-conscious, thought his whole life about, I don't know, side effects, then it's very difficult to make him very open. So, but we'll see the other, certainly educational level, also IQ, or maybe yesterday at the dinner, someone, Peter Uren, said about spiritual intelligence. I think it's a very important concept. If you need some spiritual intelligence or psychological intelligence to profit really from these still very intense experiences.
Thank you, Dr. Hasler, for your presentation. I have a question.
Who are you?
Here. Thank you very much. It's very insightful. I have done this therapy in the past, and it changed my life very positively. I have experienced the classic side effects such as nausea, headaches, and severe fatigue. However, one session struck me. It was not a bad trip. It was a tough trip with LSD. And I experienced the next day the loss of eyesight of my left eye, which lasted 24 hours. Now, I want to add that I had severe myopia, -18, for many years, and I have done a surgery more than 25 years ago. So while integrating during that 24 hours, understanding why I lost the eyesight, I concluded for myself that perhaps this was linked to my tough trip, as it was related to, I relived severe traumatic experiences that I experienced working in conflict countries. So that was for me a conclusion only for myself, as I felt it during my integration, that this is why I lost eyesight on my left eye. My question to you is, have you come across similar cases where patients have lost their eyesight temporarily and perhaps related to previous conditions such as high myopia? Thank you.
Yeah, that's a very important remark. Maybe not so good experience, I must say, you had. I mean, any kind of visual problems is certainly well known. It's also in our new scale. But losing eyesight, I never heard about this. It's severe, you know, and I'm sure you didn't know what it is, and you didn't know it doesn't come back, and it must be horrible. So that's certainly something, I don't know. I mean, there may be way more experienced people in this room who may know that. But I think it still tells you that's problematic, that we have to inform patients about these kind of severe side effects. I'm very glad it resolved. I mean, that's still a common theme, that everything resolves, which is really true. Yeah, but I think we have to collect more data and be really open about this, about rare side effects. But that will happen if you do more treatments. That's with all substances. In the beginning, you have a small list, and the longer you have, then the companies have to all collect these side effects. That would be a very important one. And then you see in the compendium, it gets larger and larger. It's also a problem if you really read that, then you get really dizzy. All these side effects. But thank you very much. I mean, that's very important information for all of us.
Thank you very much. I'm here. Hello. De l'autre côté. I have a question.
Left side.
Hello.
Yeah.
Yes, thank you very much. You already spoke about that a bit, but can you tell me a bit more about anticipation? Because the patient, they see the treatment in one way, and of course, if you look at the miracle cure, you're going to have more positive anticipation, and if you're very anxious and you're afraid of a new therapy, you will have more side effect. Can you speak a bit more about that?
Certainly, I mean, they all come with certain expectations, be it healing or side effects, etc., or they're anxious or less anxious. And certainly in the preparatory phase, you have to assess this expectation, kind of work on this expectation. But it will also say anxious people or people who have never had a psychedelic experience, they're in the first session more anxious. And in the case like in what Peter Gasser wrote, then it may get better over the sessions. But, and you know, so compulsive traits, they're always negative. You know, when they want to control everything, like in OCD, you really know from the beginning. I mean, I have a pretty good guess how many side effects they have. But it's not perfect. Sometimes it's totally unexpected that very anxious people have a very positive mystical experience, and very positive people have a rather unpleasant experience. But certainly this expectation is very important in preparatory phase, that you know the expectation and also reject the patient because their expectation was so different from scientific knowledge, and I couldn't change the expectation. I said, I don't do it.
Thank you.
Hi.
Back here.
Back here. Sorry.
Here, yeah.
Yeah. Hello, doctor. Thank you very much. I have a question concerning the trial with placebo, MDMA. how do you produce a placebo with MDMA? I mean, like technically, how can a patient not be able to distinguish between placebo and MDMA?
Yeah, that's a very important question, by the way. That's in a way with psychedelics, as with psychotherapy and other methods like massage or so, there's no real placebo. But you must say the whole medical world, there are many, many treatments without the placebo. But there's no real placebo because you experience it. But there are tricks what you can do. You do, for example, like in Frederica's study, you do different dosages, and you just assume that the high dose would be more effective than a low dose, for example. But it also shows in psilocybin, I think Griffiths did a full placebo, but the setting was right and everything, and then in the placebo group said they had the most significant spiritual experience in their life. So the setting is also quite important. The other thing, you take alternative substance, you take some Ritalin or any kind, in the ketamine trials, they sometimes take midazolam, or it's all not perfect because they also have effects. But really, the long story short, there's no real good placebo, but as I said, that's quite common in medicine in general. Psychotherapy, there's absolutely no placebo.
Okay, thank you.
Hello. I'm wondering about, you are speaking about side effects, and I'm wondering if the body preparation, the body anchoring before to take psychedelics reduce this kind of side effects, and also if the therapist can touch the patient during the session when he has allowance to do that. Do you see a reduction of negative experience that is overwhelming for the patient and has an impact afterwards?
I mean, I understood the first part. If you can be prepared, and I say clearly yes, for example, some meditation training is quite good. So some patients, I send them to yoga or do anything like this. So they get prepared. So kind of this mindfulness to not do anything and to accept the experience. Or if they do acceptance treatment. Certainly physical health is also a good thing. It's healthy food, healthy body. I mean, it's a bodily experience. That's also certainly a good thing. But there's no, so far, really specific preparation. So unless mindfulness or... And the other thing that you really learn, have a lot of time in the preparation phase, you really learn the patient. And very importantly, I think that you don't have conflicts. Exactly, that you don't have very different expectations. You know, for example, one patient, it started slowly. It was also, we were so great, and we're doing that. And then she just said, yes, she would like to have a candle. I said, okay. But then the hospital said, no, there's no candle allowed. And I told her, but she was really angry. And then we almost got in a fight about candles. So I saw it's not possible. I mean, it's not psychoanalysis where you think you go through the candle, unconscious meaning of the candle. Also, that would be interesting. Why it really needs a candle for the treatment. But yeah, I mean, I said we do more preparatory sessions unless at this state we have conflicts and things are not clear and I don't really understand why this is so important, then you cannot do the treatment. I think it's very clear that you have a very solid basis between you and the patient. But we have a second part of the question. I didn't completely...
My question was if when the patient has more bodily consciousness, if the side effects reduce.
I mean, that's certainly one you do. You say if there's a very difficult situation, maybe sit up or breathe slowly. Yeah, you do kind of, or you do body check things. Yeah, you need some kind of, parts of the embodiment treatments or body treatments, therapy, some of these tools are used. And certainly if the patient is already very good at this in, for example, respiration, controlling respiration. That's certainly an advantage.
All right, time for one more question. Is anyone next or not? If that's not the case, thank you very much, Mr. Hasler.